Good morning, everybody, and thank you for joining us for ECQM's Reviewing EHR Challenges and 2017 IPPS Final Rule Changes. My name is Mike Saperstein. I'm a marketing manager with Spectrumetics. Before we begin, I'd like to go over a few quick housekeeping items. At the end of the webinar, there'll be a brief Q&A session. Feel free to enter your questions in the webinar control panel anytime during the presentation, and we'll address them at that time. Additionally, in the middle of the webinar, there'll be a short break for poll question. Please take the time to answer it, as it helps us to refine our webinars and provide even more meaningful content in the future. After the webinar, we will send each attendee a follow-up email containing highlights from the presentation. First, I'd like to introduce today's panelists, the first being Dr. Raj Lakhanpal. He's the founder and CEO of Spectrumetics. Additionally, he is a member of the National HIMSS Clinical and Business Intelligence Committee and a member of the Board of Trustees of the University of Sciences in Philadelphia. Prior to Spectrumetics, he founded Health A to Z, an online wellness and population health management platform that assisted health plans and other clients to reduce their healthcare costs. He is also a fellow of the American College of Emergency Room Physicians and the Royal College of the Physicians and Surgeons in the UK. Next, I'd like to go over our agenda. First, we're going to cover ECQMs and the EHR challenges. Second, we'll review the IPPS Final Rule changes. And finally, we will detail the Spectrumetics solution for ECQM reporting. Now, without further delay, I'd like to turn the presentation over to Dr. Lakhanpal.
Hi, good afternoon, everyone. This is Raj Lakhanpal, and it's a pleasure to present to you. Joining me in the presentation will be my colleague, Mark Bryant, as well, who's Director of Sales. So this is an important slide. It's a simple slide. It's an important slide. It tells what has changed for 2016. If this is the first webinar you're attending with us, I like to start off with this slide because I think it starts off setting the stage. So in 2016, the 4 ECQM reporting is mandatory for HIQR. And you can leverage those 4 ECQMs to report not only for HIQR, which is hospital and patient quality reporting, but also meaningful use, the Joint Commission, as well as meaningful in the Joint Commission. And the deadline for that is 2/28/2017. You need to report for 1 quarter, either Q3 or Q4, for all the 3 programs. And the penalty is it adds up to about 1.4% of your total Medicare reimbursement for not doing this. PQRS, it's 9 measures across 3 domains, but that's a different presentation. Today, I'm going to talk of ECQMs for IQR, MU, and TJC reporting. The reporting needs to be in QRDA1 category format. We'll talk a lot more about that. And it is critical that you plan reporting for it, right? If you have not started reporting, if you do not have a vendor to help you, it is critical that you start today. Next slide, please, Mike. So why ECQMs? I think most of you probably know about it, but just so that I can say that ECQMs capture data as opposed to clinical quality measures, regular manually abstracted measures. ECQMs capture data electronically at the point of care. As the care is being provided, they capture data that's entered into the electronic health record. They absolutely reduce the manual chart abstraction burden, and they also obviously assist with regulatory reporting to satisfy quality programs. But once you capture ECQMs, you can report for multiple programs. And very importantly, as we move to value-based care, they also will assist you with continuous quality reporting, how your health system's doing, how your EPs are doing, that on a monthly basis or a quarterly basis, they can help with that. Next slide, please. So about a year back, in the spring summer of 2015, CMS did a survey. They surveyed 29 hospitals to find out how they were placed in terms of reporting to CMS, and also assess the hospital and CMS readiness to support ECQM reporting, and how CMS could modify, could improve their approach for the hospitals to speedily implement ECQMs. And did they need to, for example, did they need to remove some ECQMs, what future requirements they needed to add as well. So next slide, please. And what they found was that generating QRDA1s was difficult for a lot of hospitals. They found that the EHR, electronic health records, their guidance for mapping data was not sufficient, and most mapping needed to be done manually by their hospital staff. Other thing they found was that workflows did not align with, sometimes the workflows did not align with ECQM specifications. The hospitals had modified their workflows or customized their workflows for different work situations. So now it was very difficult to collect that data in data elements, discrete data elements that were needed for ECQM reporting or for QRDA1 generation. And also, as an example, it says a patient transfer process. For example, when a patient gets transferred from the ED to the floor, there were different time that was which event best corresponded to the intent of the measure. For example, they could be when the order was written to admit patient to the floor, when the patient was actually delivered to the floor, when they came to collect the patient from the ED to the floor. So all that different definitions of ED transfer time, they needed more clarity on what really was the intent of the measure. So this was the CMS's collection of what the feedback was. Next slide, please. Now, a year later, the TJC did a survey in the summer of 2016. So this is very recent, and they had about close to 320 respondents. And here the results were much more encouraging. They felt that many hospitals felt that the 2017 deadline to report the 4 ECQMs I talked about is achievable. They felt that they still needed more time for education resources to report. And on the other side, only 13% of the hospitals, that's the right rectangle on the upper right, 13% of the hospitals had submitted patient-level data to CMS, and they wanted the EHR vendors to help them more. And the next slide details what the results of the survey were. So 86% of the hospitals will submit ECQMs in February 28, which was a huge jump. 87% felt the state date was achievable. And then if you look down the red ones, 58% did not know how to generate a QRDA1. 79% had not successfully generated a QRDA1, and 87% had not successfully submitted to an ECQM patient-level data, which is again a QRDA1, to CMS. So a significant percentage, 86%, felt confident that they could report, and close to 87% had not so far successfully submitted ECQMs to CMS. Next slide, please. So this is talking about the final rule for HIQR on calendar year 2016. There are 28 HIQR CQMs. you have to report 4 ECQMs this year for 2020 to 2017, by 2017. You can self-select them. You only need to report 1 quarter, either Q3 or Q4 data. So that's this year. Next year, you will need to, the differences are that CMS has reduced the number of ECQMs that are available to you, and we'll talk about that in a minute. You have to self-select 8 of them. So from 4, the number goes to 8, and then you have to submit it for the entire year. So it is in your interest to report this year, so that next year when it's 8, you have, you're walking down a path that's good for you. Next step, please. Next slide. MU, this year the 4 ECQMs you report for HIQR can be the 4 ECQMs that you report for MU2. So Q3 or Q4 exactly like HIQR, or you can attest that you can report on all 16 ECQMs this year. So those are your 2 options. There are 29 ECQMs instead of 28, and the one that's MU has ED3 as well. Next year, again, from 29 it goes down to 16. You have to report 8 ECQMs, and you have to report it for the entire year. So HIQR and MU this year, next year are the same, the number of ECQMs you need to report. And you can attest as well for the whole year, for next year as well. If you're submitting HIQR and MU, you have to report. You cannot attest. And then for calendar year 2018, you have to submit all the ECQMs electronically. So this year 4, next year 8, 2018 calendar year, all need to be submitted electronically. So again, as I mentioned before, it is in your best interest to start reporting ECQMs this year. Next slide, please. Okay, so these are the ECQMs that are available to you for reporting. And these are 16 ECQMs. So as I mentioned earlier, ED3 is only applicable to MU. It's not applicable to HIQR. Next slide, please. And this is a nice slide. It tells so we were going down from 29 to 16 ECQMs, and here's the reason why. So the ones in the first column are topped out for AMI 2 and 10 and skip 1 and 2. Topped out means that CMS is saying there is no significant improvement in outcome that can be achieved with these measures. The next one is no longer maintained by the measure steward. And for pneumonia 6 and skip 9, it's difficulty documenting timing and lab results. And then for VTE is the difficulty. There was difficulty capturing data electronically. And then for AMI 7, there were high exclusion rates. So in this case, they were looking for thrombolytic therapy. A lot of PCIs were being done. Percutaneous coronary interventions were being done, which was not a part of the measure. So they were excluding a lot of patients. So they have also decided to remove that ECQM. So good for all of us. Instead of 28 to 29 ECQMs, 28 for HIQR and 29 for MU, we're down now to 16 ECQMs to report from. Next slide, please. So this is more for EMR vendors. The EMR technology or the certified EHR technology that you're using should be certified for either 2014 or 2015 version for this year and next year. And from 2018 calendar year reporting, it needs to be certified for the 2015 version. And currently Spectromedics is certified for 2014, which will be good for this year and next year reporting for us too. but we will be moving to 2015 in the latter half of next year. Next slide, please. Mike, you want to take over?
Thank you very much, Dr. Lakhanpal. We'll now take a moment to answer our poll question. What do you see as your biggest challenge with ECQM reporting? The four answers are extracting data from multiple sources / data mapping, aligning clinical workflows to satisfy ECQM data requirements, identifying appropriate ECQMs to calculate, generating the QRDA1 file that satisfies CMS submission, or choosing an ECQM reporting partner. We'll give everybody a couple seconds and we'll be right back with the results. Okay, everybody, it looks like the overwhelming answer is extracting data from multiple sources and data mapping. Now I'd like to turn the presentation over to Mark Bryant, who I stupidly forgot to introduce. I apologize, Mark.
No problem, Mike, and good morning and good afternoon.
Medics.
Thank you, Mike. Good morning and good afternoon, everyone. Really grateful for your time today. So for my part of the presentation, I'm going to talk a little bit about who SpectraMedics is, what our certifications are, what we offer, and then what our engagement process looks like. So first, our overall goal is to help hospitals and health systems make the transition from fee-for-service to fee-for-value and risk-based models. And we do this in three ways. The first is being able to consolidate data across disparate systems, and from your poll questions, we know that that is a big challenge in extracting data, and I'll talk specifically to how we can help for ECQMs. The second is our measurement framework to be able to report for both hospital and ambulatory programs. And the third piece is predictive modeling, both for inpatient readmissions, value-based purchasing, and also population health for stratification and disease registries. I won't spend any time on that today, but if you have specific questions, happy to address that separately for you. And then below are some of our select clients and partners. We can certainly give you a full client list if you wish, but just to recognize a few. First is Haney Solutions, which is a division in the Hospital Association in New York. We're very proud of our relationship with Haney's. They've endorsed our PQRS solution. With that relationship, we formed partnerships with Greater Hudson Valley Health System, Auburn Community Hospital for PQRS reporting. Our newest relationship from that is Oswego Health, who will be helping with ECQMs and PQRS reporting for this year. Underneath New York Disrupt, which is a Medicaid reform program in New York State, and it's around in other states as well. We're working with Mount Sinai, who has a Disrupt program. They also have a clinically integrated network as well, 3,400 providers that we're providing a measure framework for both of those programs to help maximize incentives and report. We're also working with the Staten Island Performing Provider System, which is also a New York Disrupt program, giving them their IT infrastructure for consolidating data, measure calculation, and a lot around population health. Also, Quantros is a distributor partnership of ours. They're distributing our ECQM platform to their hospital relationships. If you're a Quantros hospital and if you have any questions on this, you can feel free to reach out to them directly or to come to us, and we can certainly answer any ECQM questions. And then finally, Oracle, we're integrating with Oracle as well, and we have a strong partnership with them too. Next slide. So the first step is being able to extract your data, and I'm going to speak in a couple future slides on how your different options for extracting the data. But below, you'll see that if we were building an interface and extracting directly from EHR, there's numerous sources that we can pull from. But the main point of this slide is that once we have the data, whether it's extracted or in other formats, we'll consolidate that data for you. We'll map it to the elements specific for the measures that you want to report on, and then we'll standardize that data, meaning, for example, we'll deduplicate any patient information for that. And then we'll populate our enterprise data warehouse. And we'll do this on a continuous basis. So every time we take in new data, whether that's on a monthly, quarterly, biweekly period, whatever the case might be with your hospital or health system, we'll run it through this process over and over again to populate the enterprise data warehouse for you. Next slide. And so what that'll allow us to do is then be able to layer our measure framework around that data and be able to report on the hospital side. We're certified for all 29 electronic clinical quality measures to report for HIQR meaningful use in the Joint Commission. We can also do other programs like value-based purchasing or custom initiatives your hospital might have. On the ambulatory side, we're certified for all 64 ECQMs for PQRS and for meaningful use. We're also a qualified registry with 169 PQRS measures to report on in 2016. We can also build district measures. That's the New York program. A lot of those measures are HEDIS-based, so we have a very good experience with HEDIS measures, accountable care organization measures, and we could do other custom measures as well for any organization. Next slide. And so I spoke earlier, and I know the poll question has stated extracting data is the toughest chore in this, and there's a couple ways that we work with our clients in order to accomplish it, because we know it is a challenge. The first is if your EHR can produce a QRDA1, we'll be able to ingest that directly from them. But we know a lot of EHRs or clients are having trouble generating that file, so what we've created is what we call our data specification file. And what that is we list out the data elements that we need for the measures that you're looking to calculate. We'll provide you that file, and then you'll populate that file and provide it back to us in some type of flat file, CSV type format. So this is a way to get around the QRDA. If you have an IT team that can run a query and provide us this information back, we can then take that flat file, ingest it, and calculate the measures. And then finally, as I spoke in the earlier slide, we do have the ability to build custom interfaces and extract data directly from the EHR. So once we have that data, we populate our enterprise data warehouse. We layer our measures around that. We then provide you dashboards for performance improvement, and I'll show you a snapshot of those in a second. And then we do all the submission. We generate the QRDA file that can be then submitted off for HIQR, can be submitted off for meaningful use for the Joint Commission. CMS has a different flavor of the QRDA1 file than the Joint Commission does. So even though you're reporting the same measures, we need to create it in different format in order to satisfy both organizations. But we can also leverage data for multiple programs outside of the three and look at PQRS and look at any NCQA programs as well. Next slide. And how we do this, how we create measures to report for multiple programs is we have underneath our platform what we call our measure authoring tool. So this allows us to rapidly define measures, update measures as they're changed each year by CMS, and create new measures to be able to support our clients that might be reporting for multiple programs, whether that's commercial payer programs, it could be a Medicaid program, if you have a clinically integrated network, accountable care organization, plus obviously the CMS programs with PQRS, meaningful use, and HIQR. And then we'll be able to, once we create the measures for each of the programs you're looking to report on, we'll then give you the ability to track those measures on an ongoing basis through a portal that we'll provide you. Next slide. And that portal has a couple of key roles. It's completely customizable, our portal for you. Each client, we sit down with them and understand what the needs are. But we see a couple of key roles that we offer or that our clients have asked us to offer. The first is an executive role. So the executive is going to look from a health system perspective or a hospital perspective at the multiple programs that you might be looking to track. If you have multiple hospitals, you'll be able to look at each of those programs from each of the hospitals' perspective. If you're one hospital, you're going to look at your program and the measures as an aggregate across your hospital, and then be able to drill down So let's, for instance, for HIQR, if you're tracking just 4 measures, or if you're tracking, let's say 10 for 2016, you'll be able to look at those measures that you're tracking and see performance per measure with some customization, some dashboards underneath it to see how you're trending. Accompanying the executive role is what we call an analyst role or an informaticist role. Again, same type of overall perspective in terms of looking from a health system or a hospital, looking at multiple programs. But the key difference with an analyst is you can drill down into the measures themselves and see patient-level details, so you can start to truly do the performance improvement, address any gaps in data, address any gaps in workflow, and make those recommendations to improve each of the measures. Tied to the analyst role is a submitter role. The submitter has the ability to go in prior to the submission deadline. So for ECQMs for this reporting year, they'd be able to go in prior to the end of February 2017. If you're tracking more than the 4 required, you'll be able to look across those multiple measures and pick the measures that are performing the best. That'll then generate a report to us that we submit off to CMS or the Joint Commission. But the submitter will always have access to that final report in our system for compliance. And then finally, we can offer a provider role. This is really good if you're looking at outpatient programs or like PQRS, and want to be able to have your providers see their patients in an aggregate and see gaps in care and utilization, see scorecarding and other disease registry type capabilities as well. Next slide, please. And so for purposes of this webinar, to be sensitive to your time, we just took a couple of snapshots of our platform, but we're happy to demonstrate it in full if of interest. The first is giving you a feel for what the executive dashboard would look like specific to HIQR. So after we drill down, from a health system or a hospital perspective into the HIQR program, what you're seeing here are the measures that this hospital is looking to track for the year and their performance. And what we provide our clients is 2 benchmarks. They could be a national or a state average, and then also an internal target. So if we're looking at the first measure, AMI 10, statin prescribed at discharge, you'll see that there's 2 benchmarks for it, and that currently this hospital is outperforming both benchmarks. We can also drill down in here and give you the ability to see provider comparisons for this measure, and this will give the executive team a high-level review for that opportunity to start doing performance improvement. Next slide, please. And then the difference with the analyst role is the analyst is going to be able to drill down into the specific measure. So if we look at VTE1 across the top, you'll be able to see initial patient population, denominator, if there's any exclusions and exceptions, the numerator, what's the overall performance, and then once you click into it, you'll get the actual patient-level details. So if we look at patient T. Lee, they were included in both the denominator and the numerator. And then we skip down to F. Brown. This particular patient was excluded in the numerator because there was data missing. So here's an opportunity to go back to EHR and remap that. If we look at T. Jones, there's multiple reasons for being excluded in both the denominator and numerator. So this will take some time for your team to review and see if that's correct, and how to remediate if you can for that. And then again, we handle all the submission to the CMS and Surgery Commission. Thank you. Next slide, please. So the next 2 slides, I'm going to talk a little bit about our engagement process. This lays out the steps in it. The first step is what we call our readiness assessment, and I'm going to speak specifically to that in the next slide. So I'm going to skip that for a second. But then there's a remediation period and implementation and training that goes on all prior to going live. So we make sure that you're in the best perspective and position before you go live in the system. And then we provide ongoing managed services and support, not only leading up to submission, but on an ongoing basis past that as well. So next slide, please. So our readiness assessment, and we feel there's incredible value here that we can offer to our clients in being able to give you a perspective of how you're currently performing prior to going into an implementation period. So first off, we work with you to understand what your EHR's capabilities are. Can you generate a QRDA1? If not, can we work with you on a data specification file and do a query and a produce a flat file of some sense to for us to ingest the data and calculate the measures. If not, will we have to build a custom interface? What are the options that we have for your hospital or for your health system? We then get a sample of data from you. So if you can generate a QRDA or give us a flat file, we'll take that in, we'll run it against all the measures, and provide you back a report up front that says, A, can you calculate at least 4 ECQMs for this year? And B, how are you currently performing against these measures? Are there any gaps? Is there any data missing that we can start to remediate, again, prior to going live for you? So basically that analyst role that I showed you in our portal, we give you a report up front to work on with our team through weekly calls with our business analyst team and our development team to address any gaps that there might be, get you comfortable that you can report 4 for this year. But also, if you're just looking at 4 for this year, we can help start to look at those additional 4 for next year as well, and start to give you a strategy for being able to submit ECQMs on an ongoing basis. Next slide, please. And so that leads into my last slide, and that kind of covered just in that last part, the value of the readiness process and being able for us to help you develop that strategy. We want to be your partners on a long-term basis to help you identify the gaps, improve workflows, and give you a tool that you can look at and track from an executive perspective and an analyst perspective, month to month, quarter to quarter, and so forth. And we handle all the submission. We take that burden off of you to be able to submit to CMS and the Joint Commission, and we can help you develop strategies for future reporting requirements as well. And so with that, I'm going to turn it back over to Mike for our question and answer session. My contact information is up on the screen. Please reach out, and me and my sales force would be happy to address your questions in further details, provide you demonstrations of our system if interested. But greatly appreciate your time today, and look forward to speaking with you. Mike?
Thank you, Mark and Dr. Lockenpaul. We'll now begin the Q&A session. We had a number of excellent questions come through during the webinar, but if you have any, please feel free to still send them. I'd also like to introduce to you Jackie Bates, who is a business analyst specializing in ECQMs, and she'll be assisting us in answering the questions. The first question that came in is, do you feel any of these ECQMs are at risk of being removed from the program?
Hi, everyone. So each year when CMS publishes their final rule, the reason that they remove certain measures is because of that they qualify for removal factor criteria. So that's what they're looking for. If a measure, for example, if it's topped out or if it's no longer supported by a measure steward, that qualifies for a removal factor criteria, and that's why these measures are being removed. CMS has stated that they intend to focus on a smaller, more specific subset of ECQMs in both HIQR and the EHR incentive programs. So with that being said, it really sort of depends on the performance of the measures in the coming years and what exactly the measures are looking for. So if it's needed, CMS will revise the measure set through future rulemaking, but again, it's hard to tell now exactly how that will play out.
Thank you. Next question. If I submit ED1, ED2, or PC01 as an ECQM, am I still required to report it as a chart abstracted measure?
So for calendar year 2017, ED1, ED2, and PC01 will be measures that are available as ECQMs and as chart abstracted measures. However, submission of ECQMs does not meet the complete program requirements for HIQR. So that means if you submit any of these 3 measures as an ECQM, that will not qualify your chart abstracted measure criteria. You will still be required to submit those measures as both ECQMs and chart abstracted measures.
Thank you, Jackie. Next question. Can a hospital change the ECQMs that it reports each quarter? And I think we're going to have...
Mike?
Yep. Okay, thank you, Mark.
Yeah. So you cannot. A hospital cannot change the measures that they need to report on. They need to select them for 2016, either Q3 or Q4, and then for 2017, it's going to be for the full calendar year. And so that's where, going back to our assessment, I think that's where we can add value to whoever asked this question, to be able to give you a perspective on how you're currently performing against the electronic clinical quality measures, so you can select the right ones to satisfy for today and in the future.
Thanks, Mark. Next question. Which EHRs do you currently work with?
Okay, I'll take that as well. So we work with a variety of EHRs, both on the inpatient and the outpatient side, from Cerner and Epic and Meditech and McKesson and eClinicalWorks and so on. But so we have the ability to work with any EHR that is out there. But again, where we try to figure out up front before we go in and have to build an interface is, can we help you get out a structured format file? If you can't get a QRDA one for hospital ECQMs, or in the case of on the ambulatory side, CCDA as well, can we help you with a structured data format and run queries that way? But we can work with a variety of EHRs.
Next, will Spectrumetics help with measure selection for reporting?
Yes, and that goes to our assessment process. So what we'll do is, as we do the kickoff, and we get that a sample amount of data from you, which we understand the best way to extract that data. We'll run it against all the measures and give you a report back up front to help you work with you to determine what measures you can report on today and in the future. So yes, we will help you on that.
And the final question is, what is your pricing model?
Okay, and our pricing model has two components to it. There's one-time fees up front that are for implementation and for the readiness assessment, and then we have an annual subscription fee model for reporting and tracking and reporting on ECQMs.
Okay, this is going to conclude the webinar. I'd like to thank everybody who participated and everybody who took their time to listen. I hope you all have a great day. Thank you.
Thank you, everybody.